headache, that is CH, SUNCT, which is a short-acting ultra-neuralgic cranial trigeminal neuralgia, and PH is paroxysmal hemicrania. We have recently reviewed that there is an area involved in the migraine where the dorsal pons, locus coeruleus, and periaqueductal gray matter. Whereas in the hemicrania continua, which shares the clinical features of both migraine and trigeminal autonomic cephalgias. So means there is an activation of both the hypothalamic structures and the brainstem structures in headaches. What is the striking feature over the trigeminal autonomic cephalgia is the autonomic component, that every time or each attack of the pain is coexistent with the autonomic features, and this is because of the mediation of trigeminal autonomic reflex, where stimulation of trigeminal efferent fibers resulting in the cranial autonomic outflow. So in this way, these are the headaches. They have associated autonomic features because of the trigeminal autonomic reflex, and there is a strong stimulation at the level of posterior hypothalamus. Therefore, they have features, some of the mimicry features of migraine as well. So comes to the first type of trigeminal autonomic cephalgias is one, and the most common is the cluster headache. Because you already gone through the primary type of headaches by last week, and here we are discussing some other secondary headaches or trigeminal autonomic cephalgias. So the first of all is the cluster headache, which is the commonest of all these, and it's contribute about 5 to 10% of the primary headaches, and these are here is the multiple headache of severe unilateral orbital, supraorbital, or temporal area of the pain. The duration of headache is lasting from 15 to 180 minutes, so it may vary, and there is multiple episodes, like recurrent episodes. So there, during the headache, you must have one of the following feature. Either there is a unilateral conjunctival congestion, lacrimation, or both. Patient might have ipsilateral nasal congestion, rhinorrhea, or both. Patient might have ipsilateral lid edema, ipsilateral myocystosis, or both. Ipsilateral facial swelling of the forehead swelling, or a sense of restlessness or agitation. So if any of the character is present along with the severe unilateral pain, which is lasting of about 15 to 180 minutes, there is diagnosis of the cluster headache can be made. And the frequency of attack may varies. It may from 1 every day to 8 per day. So this depends upon the intensity or the severity of the cluster headaches. Now, what this has been, I already told you the commonest type of the trigeminal autonomic cephalgias, and there is incidence of about 0.1%, with predominantly seen in the males compared to the female with 3:1 ratio. It has been seen it has this association with circadian rhythm and usually occurs at night, and the patient may awaken at night from the sleep when the headache becomes intense. So most often seen at 90 minutes after falling asleep. There are certain triggers or the stimulating factors such as strong smell like a paints, perfumes, petrol, or sometimes by ingestion of alcohol will also induce the typical attack of the cluster headaches. So there is a type of episodic cluster headaches, or sometimes it occurs in the bouts and it clusters. Why it is called as clusters? Because there is episodes of recurrent headaches which is lasting for weeks or a month at a time, and then there is separated by a remission period of a month or year. So they occur in bouts for few days to months, and then there is a period of remission. Then there is no headache, and that was lasted for about a month and a year, and then we have again recurrent attack or bout of the headache. That is why they were termed as cluster headaches. The patient with an attack of more than an year duration without a remission of a month, they were termed as chronic cluster headache. So chronic cluster means there is persistent attack of persistent attacks of headaches lasting for more than a year, and there is no remission phase developed between them. They were termed as chronic cluster headaches. So this is the diagnostic criteria for the headache. And how will you treat? So you need to treat as acute attack and prophylaxis for the drug. The symptomatic or other acute attack of headache needs high flow oxygen of about 8 to 12 liters per minute for about 15 minutes or till the patient attacks abort. Sometimes we need to go for injectable sumatriptan in the dose of 2 to 6 milligram, which is maximum of 20 milligram, 12 milligram per day. And you have to bridge your treatment along with a high dose of steroids as well till your prophylactic medicine start working, because it takes about time of week or so. So you have to treat the acute attack with high flow oxygen, injectable sumatriptan, or sometimes high dose steroid while required. Later on, you have to put the patient or switch the patient to prophylactic drugs that include verapamil, sodium valproate, lithium compounds, topiramate, or especially for when you have suspecting the period of clusters. So you have to put them on these prophylactic drugs. Now comes to the second type of the trigeminal cephalic autonomic cephalgias is the hemicrania continua. These are the headaches which are usually unilateral. They have unilateral headaches lasting for more than 3 months. So the patient presented to you with a unilateral headache which is more than of 3 months and associated features are, then you must think of hemicrania continua. What are the pain characters? Must be unilateral without any side shift. They have a daily continuous headaches without any pain-free period in between. And these are the headaches of moderate intensity with on and off exacerbations. Along with that, you must have at least one of the autonomic feature during that ipsilateral headache site, that is nasal congestion, rhinorrhea or both, ptosis, neosis or both, conjunctival congestion, lacrimation or both. And these are the headaches which are usually prevented by indomethacin. So whenever you place the patient on indomethacin, which is an NSAID drug, these headaches resolve, and this is also the diagnostic point that patient might have hemicrania continua, because they do respond a lot on the management while they were placed on indomethacin group of drugs. Now, third type of trigeminal cephalic autonomic neuralgias are chronic paroxysmal hemicrania continua, or you can say the paroxysmal hemicrania. These are the headaches are similar as hemicrania continua, but the difference is that they had duration of attacks are different and they have more frequent headaches. So at least 20 attacks of headaches are there, along with the autonomic features of congestions and lacrimations, or sometimes both. And these also are the headache of unilateral onsets with severe intensity, having supraorbital or temporal pain, which is lasting for 2 to 3 minutes. So the associated autonomic features are the same. They have must have at least one of the following character, that is ipsilateral conjunctival congestion, lacrimation, or both, ipsilateral nasal congestion, rhinorrhea, or both, ipsilateral lid edema at the eyes, ipsilateral forehead or facial swelling, ipsilateral meiosis or ptosis. So these attack frequency may vary, like patient might have 5 per day or sometimes more than half of the time of the day expanded with these type of headaches. So at least whenever there is a 20 attacks of headache, you must think of chronic paroxysmal hemicrania. Chronic hemicrania continua were termed when it is more than 3 months, but these are the headaches. They did not require duration of 3 months. They if you are having attacks of 20 or more, and these attacks were usually lasting for 2 to 30 minutes and they occur more than 5 per day, then you can term it as chronic paroxysmal hemicrania continua. And these also the headaches which usually responded on therapeutic doses of indomethacin. So hemicrania continua of both type, they responded with the dose therapeutic level of indomethacin. Now, the attacks of paroxysmal hemicrania are similar to chronic cluster headaches, but they are of shorter duration and occur more frequently, because we termed that the cluster headache lasting for about 180 minutes, till 180 minutes, but it may vary. They occur in the clusters. Whereas paroxysmal hemicrania are attacks which is lasting for 30 minutes maximum, and they have associated ipsilateral autonomic features. Both have been same autonomic features, but the diagnostic point of paroxysmal hemicrania is the attacks are usually abolished by indomethacin. So this is the diagnostic point, that paroxysmal hemicrania responded well with indomethacin and cluster headaches do not. The drug of choice for chronic paroxysmal hemicrania is indomethacin, especially when the patient experiences frequent unilateral headaches of more than 4 attacks in 24 hours. A drug trial of indomethacin should be considered in any patient when you are suspecting of hemicrania continua or chronic paroxysmal hemicrania or cluster. The dose of indomethacin should be increased to at least 150 milligrams per day for 3 to 4 days. A beneficial effect seen usually within 48 hours after, but it may take as long as 5 days. So it was seen in one study that indomethacin was complete within 24 hours in most of the patients. Sometimes it can be approached to its maximum effect within 8 hours. So the maintenance required dose is 25 to 100 milligrams per day. The pain lasts lifelong in hemicrania. So the patient who are suffering from hemicrania continua, they must have required a long-term treatment with pain because they have long-term symptomatic problems, so they required indomethacin require long-term. While in case of the chronic paroxysmal hemicrania, patient might undergo in the spontaneous remission phase, or sometimes they required the symptoms remain lifelong. So the prognosis is variable in both the scenarios. Now the third type of headache, which is SUNC syndrome. It is a very rare type of attacks, headache syndrome, and it's termed as short-lasting unilateral attack with conjunctival congestions and tearing syndrome. These are the very brief type of attacks, and you need to have at least 20 attacks of headaches for the diagnosis, and these attacks are usually unilateral, supraorbital, or temporal. They have a stabbing or pulsatile type of quality, and they last for 5 seconds to 4 minutes. So the duration is very, very brief, and they have association of conjunctival congestion and lacrimation on the same side. The attack frequency may vary from 3 to 200 per day. So these are the very brief attacks of headaches, and it's a very rare type of headache syndrome, and they do responded a lot on these drugs. That is the anti-epileptic group of lamotrigine and topiramate, and the benzodiazepine group of gabapentine. The headaches of these SUNC group, they do well responded on these drugs. There is no association of nausea and vomiting with these type of headaches. Now comes to the trigeminal neuralgia, which is the most commonly encountered type of trigeminal autonomic cephalgia in our clinical practice, and this is the most common neurological cause of pain, especially in the region of face and the distribution of trigeminal nerve. The pain symptoms are worsened seen on the distribution along the second and third division of trigeminal nerve. The most common trigger factors are like washing face, facial movement because of the chewing while touching. Patient may get stimulus through while shaving of the face, and sometimes the severe or the sharp breeze over the face or the windy air, it can stimulate the trigeminal neuralgic bouts. So these are the paroxysmal attack of the severe facial pain lasting for seconds, and they comes in the bout. These are the sudden, sharp, electrical current-like stabbing in quality. They're seen in the distribution along the trigeminal nerve. However, they are precipitated by touching or moving the trigger region, and there is an absence of symptom between the attacks. So these are the very sharp and the brief pain episodes. These are the patients, they require investigation because it has some underlying cause. So you should have neuroimaging with contrast study and the arteriogram, because it has been seen that one of the commonest cause for this trigeminal neuralgia is the presence of aberrant artery loop around the trigeminal nerve, and this artery loop is called by superior cerebellar artery. So you must have need of MRI brain with contrast and MRA to rule out the vascular and some structural cause of trigeminal neuralgia. It has been seen there is some association with demyelinating disorder as well. So how will you manage the trigeminal neuralgia? You need to go for some pharmacological treatment and some non-pharmacological or the surgical options. Usually these are the patients, they do responded on carbamazepine, phenytoin, and sodium valproate. But those who are refractory to the medical treatment, you need to go for the some neurosurgical options to treat the underlying cause, the gamma knife procedure, radiofrequency ablation of the stimulated nerve, or vascular decompression if there is vascular malformation or some arterial loop found around the trigeminal nerve. So in this way, you can treat the trigeminal autonomic cephalgia, that is trigeminal neuralgia. So hope till here you can understand what I'm telling to you. Okay, now it comes to some other secondary headaches. Just as name said, the secondary means these are the headache. They must have some underlying cause. So I'm going to touch some of the commonest secondary headaches which usually we encountered in our clinical practice. One of the headache is termed with the pseudotumor cerebri or idiopathic intracranial hypertension. So basically, these are the headaches were most commonly caused by underlying, they can occur as the post-infectious phenomena in the brain or because of the venous sinus thrombosis or the venous system blockade because of any reason, either from secondary to infections or maybe because of underlying mass or something else. And secondarily, these are the patient develop these type of headaches, mostly seen in the patient who are obese and especially for females. It has been seen especially in the age of 30 years. These are the pulsatile headache of moderate to severe intensity. They have associated visual problems, especially the decreased vision, blurring of vision, or diplopia, which is usually bilateral and the predominant symptom while the patient comes to you. The daily headaches, and these headaches are the headaches required investigations. When you did the examination, you may found the papilledema in about 90 to 95% of the patient, whereas associated sixth nerve palsy, so in about 50 to 60% of the patient. The reason why these symptoms, these signs were present on examination is that because of the raised intracranial pressure. So when there is a blockage in the CSF drainage because of any cause, either because of the post-infectious phenomena or because of the venous system blockage, like if there is an underlying venous thrombosis, venous sinus blockage, the patient may develop idiopathic intracranial hypertension. Sometimes it has been seen with secondary drugs like chronic use of vitamin A, steroids, some immunosuppressive drugs can provoke, oral contraceptives can cause idiopathic intracranial hypertension. So the drugs could be the sole factor of development of this disorder. So how will you investigate this patient? These patients require the CSF studies. First of all, you have to rule out the structural cause, the infectious cause. So you must go for MRI brain with contrast study. You need to have lumbar puncture to look for the underlying infection. MRV, that is a venogram, to look for underlying sinus thrombosis, any of the venous sinus thrombosis. So whenever you find the cause, you have to treat. If the drugs are the cause, you have to remove the drugs. You should go for osmotic diuretics, that is carbonic anhydrase inhibitors, to reduce the pressures. You sometimes need go for optic nerve fenestration if there is a threat to the vision, because there is a raised ICP can lead to the blockage or optic atrophy. So you have to make the fenestration at the optic nerve to save the eye and the vision. And lumboperitoneal shunting or sometimes the ventricular peritoneal shunting to reduce or bypass the raised ICP. So in this way, you can save the vision and improve the headache symptoms. Now, comes to another type of headache which usually we encounter in our clinical practice is the subarachnoid hemorrhage. headache secondary to subarachnoid, and these are the sudden, severe, sharp thunderclap headaches, which comes especially in the emergency with acute headache of severe intensity, and they have association of nausea, vomiting, neck stiffness, and altered sensorium. So these are the patients usually more than 50 years of age, and they have found to have underlying some vascular malformation, especially the saccular or the Barry aneurysm. And these headaches have a bilateral onset. They might have underlying paroxysmal attack, or they might have some sentinel headaches in their history in the past, which were missed. And by that time, these patients come with a sudden severe thunderclap, or the ever worst ever headaches can be termed under the heading of subarachnoid hemorrhage. Whenever you are suspecting this, you must go for the imaging, and the CT scan brain is the emergent and urgent available neuroimaging, which can be done in the ER. You have to look for the to rule out the hemorrhage. And whenever you are suspecting there is a blood in the cisterns or the subarachnoid spaces, you must need to have a MRI angiography or CT angiography. And CT angiography is to rule out, to look for any underlying vascular malformation, because these require aggressive management by reduction of pressures. Something you need to go for the intervention, like you have to treat the vascular malformation in acute grounds, or you just manage the patient conservatively for a few weeks, and then later on you have to plan for surgical option or coiling to obliterate or to reduce the flow in that AV malformation or Barry aneurysm, to prevent the re-hemorrhage, or to prevent the again in the future attacks of the subarachnoid hemorrhage. The long-term consequences of subarachnoid hemorrhage is the hydrocephalus. So you have to monitor serially these patients, because of the due to the blockage of the CSF drainage, as there is a blood in the CSF spaces. These patients may end up with acute hydrocephalus, so you have to manage it. And if there is acute hydrocephalus, you need to require the shunting, or in the form of ventricular peritoneal shunting, or you need to have the extra ventricular drain as well to reduce those headaches. Another type of headache which we are exposed or we are encountered in our clinical practice is the joint cell arthritis or the temporal arthritis. Basically, this is also the cause of the secondary headache, and here most often we have seen these headaches in a patient of more than 50 years of males, and the temporal arthritis is predominantly seen in the females compared to the male. It has been association of unilateral or bilateral headaches, sometimes often temporofrontal. These are headaches of mild to more severe intensity. The symptoms may vary, maybe have throbbing type of nature, dull aching character, or sharp severe pain. It has been seen there is association of polymyalgia rheumatica. In about 50% of the cases, patient might have history of jaw claudication, history of weight loss, generalized weakness, malaise, and jaw stiffness. And they have, when you worked up, they were found to have raised ESR and CRP. These are the headaches where you need to investigate. You have to do for the MRI or the neuroimaging to rule out the structural cause. So basically, there is involvement of temporal artery. You need to go for the vascular assessment, that is Doppler ultrasound of the temporal vessels, to see the flow in the vessels. So there is a restriction of the flow, or there is a high index flow. Plus, you need to go for the CT angiogram or MRA to look for the temporal arthritis. However, the diagnostic confirmation has been made on the biopsy of the temporal artery. That makes there's arteritis or the inflammation of the temporal artery. And these are the patients, they have a strong and a very excellent response to the steroid. The symptoms may improve with the use of steroid. The inflammatory markers got reduced with the administration of steroids. And now another type of headaches which usually have association with underlying primary or secondary tumors of the brain They can occur at any age, in the childhood and middle age or the late age. So the primary or the secondary comes to the brain can cause unilateral or bilateral type of headache. They have underlying throbbing or mild to severe intensity of headaches. Usually they are progressive in nature, and most often you may have underlying papilledema. So headaches over here can be symptomatic according to the site involved. So it could have a raised ICP, can produce up visual issues. The patient might have nausea, vomiting, vertigo. It depends upon the site area where the tumor lies in the brain. And if there is a vascular pressure is raised, or when there is ICP is raised, patient might develop hydrocephalus, or patient might have seizures. The patient might have motor weakness of that side or sensory involvement. Sometimes patient might have speech issues. So it depends where the tumor lies and what type of tumor it is. And in clinical practice, we have seen some metastatic disease also came to the brain from lungs in about 60% plus cases. 14% of the breast tumors can metastatize to the brain, and similarly about 10% of the skin disease, that is melanomas, can shows the secondaries to the brain. So whenever you are think of brain tumor, you must have MRI imaging of the brain with contrast, MRA and MRV, because any tumor, they have hypercoagulable state, or if it is secondary, sometimes secondary may came to you in the brain from some distant organ of the body. And you have to look for the cause. So treatment over here, obviously you have to treat the tumor, whatever the intensity of the tumor, whatever the histopathology helps you. So sometimes you may require the surgical removal, or sometimes you just go for the chemotherapy and the radiation or the gamma knife procedures of the tumor removal to improve that underlying headache. And the cause of the headache is the paranasal sinusitis. You have heard of that there is a sinusitic headache of any age, and the patient usually comes with the headache of frontal region, especially if you have the forehead region, if there is a frontal sinus involvement. If there is inflammation at the maxillary sinus, the headache or the pain may be seen at the region of cheeks with the headaches, or at the region, if there is involvement of ethmoid sinus, there is pain lies between the eyes. So it can be mild to moderate dull aching, or it can be severe in intensity. There may be association of fever, nasal discharge, nasal congestions, or purulent nasal drainage. So whenever you think of sinusitis, go for the paranasal sinuses X-rays, or confirmatory investigation is CT paranasal sinuses, in which you can look and confirm there is inflammation or any fluid-filled spaces in the sinus. So you have to manage accordingly. Here we need assistance from the ENT department to relieve that headache. So you have to put the patient on anti-inflammatory antibiotics if it is bacterial in origin, or sometimes drainage of the sinus or clearing of the sinuses may help a lot. Lastly, but not least, another type of headache which we usually encountered in our clinical practice is the post-lumbar puncture headache. As you know, the lumbar puncture is a very commonest procedure required in our neurology practice, especially when we are think of some underlying CNS infection, subarachnoid hemorrhage, or raised ICP like benign intracranial hypertension or the pseudotumor cerebri. So it is the most commonest procedure done in our practice, and post-procedure patient may develop headache. And these are the headaches which are usually developed after the 6 to 72 hours of lumbar puncture. And it could have occipital, mostly bifrontal or occipital presentation. It has a throbbing intensity, and it has been seen as worse on upright position. Sorry, the spelling is not correct. Whenever the patient is sit up or stand ups, they encountered severe type of headache because of the drop of the pressure. So basically what happened, if we did the lumbar puncture through a wide bone needle or very rapid drawing of the blood, and the patient hydration status is not good, sometimes these patients may develop post-LP headache. And here are the symptoms are similar to the CNS infection. Patient might develop worsening of the nausea and vomiting. The patient may have visual issues. Patient might develop neck stiffness. So here you have to treat the headaches by means of adequate hydration, along with some caffeinated compound can help a lot. But if these headaches were not improved with the oral drugs or caffeinated compound, you need to have an epidural blood patch. So the site which was used for the lumbar puncture had to be sealed by means of blood patch. You have to take the sample of the same patient from a blood sample, and you have to insert the blood over the site from where you got the CSF. So in this way, that the area has been sealed by a blood patch, and that will improve the headache, which was not responsive on the drugs or all your measures. So here, this is the end of the session. We have a lot of other types of headache as well. Sometimes post-traumatic headaches were also seen as a secondary headache. Like if the patient had any trauma to the head because of epidural collection, because of the subdural collection, they can have headaches. So you have to go for historical ground. Secondary headaches can be like this at post-traumatic. Sometimes patient may have hypnic headaches. Sometimes patient may have headaches are secondary to raised blood pressures, because if there is a persistent hypertension or the patient is not on any drugs, they can develop headache as well. So you have to look whatever the cause. By your detailed history and examination will help you a lot that what type of headache it could be. And if you are thinking of secondary headache, the patient must have some investigation that include the neuroimaging and the symptomatic workup. So especially the brain MRI with contrast study is mandatory, especially when we are looking for the secondary type of headache, because we have to rule some structural cause, which may be the responsible culprit for secondary headache. Till now, there is the end of the lecture, which we have done, the trigeminal autonomic cephalgia and secondary headaches. Any of the student would like to ask question or anything which was not properly cleared, can ask freely. Um, okay, you can. I would not recommend a textbook from you people because you are a student. So I think if you have read this, no, it could not in the Davidson. Basically, I would take out these from the different topics. Like I would not recommend the Adam Victor or the neurology textbook to you. Just go if you want some of the detail or the brief points on it. So you can go from the current neurology, which is in another short version of the text of neurology, the current neurology, like this. No, no, no. I'm saying that caffeinated compound would help in the headaches, not all type of headaches. It's just because of the post-lumbar puncture headache. The exact pathophysiology is not known, but it was said that if you put the patient on analgesics, those have combination with caffeinated compound, or ask the patient to take caffeine, it has a central role and it improves the headache. However, the exact cause is not known. But we have seen in our clinical practice, the patient do responded on the analgesic. Those have combination of caffeine, like have you heard of some of the name like tremol compound or the distalgesic compound? So they have a caffeinated association of analgesics. So they do responded on that. Migraines were the bit of primary headaches, and the topic of primary headaches were already taught by Dr. Naila. I think I don't know who taught you, but it was mentioned in the last week of syllabus, and I think must be explained by someone else because I'm dealing those who are not comes under the heading of primary headache, that is trigeminal autonomic cephalgia, and my topics are secondary headache. So I am not dealing with the migraine. Okay, it was, I think, already taught you. You might miss that class. Concussions and I already told you the traumatic injuries, head injuries that comes under the secondary headache. Concussion and epidural hemorrhage, subdural hemorrhage, the all collections were come under the heading of secondary headache. However, the migraine is not under the secondary. These are the primary headache, migraine, tension type headaches are primary headache, and on the topic of the primary headache were already told you. Okay. Okay, the lecture can be emailed. Yeah, sure. Okay, thank you very much. Zara, I'll mail you the lecture and there is no issue.